Okay, sorry about that, you guys. So please look for us in the future. We're always trying to bring important information to the community. I also want to acknowledge Sonia's here, and she's representing the wonderful work she does, but she's also representing the Race Academy, which is also part of the School of Social Work at UNC Charlotte. And you can learn more about them on the website. But they, as you can see, do a lot of work around advocacy around race and social equity. Okay, so this is what we're going to engage in today. I'm going to start us off with quick mindfulness and a short introduction so that the panel can have their full time. Sonia is going to talk to us about suicide in Black adolescents from an intersectional perspective. And then we have Michelle, who's going to be talking about Black women's mental health from a gendered and racism perspective. And then we're going to end with Victor Armstrong, and he's going to talk about suicide in the Black community from an equity perspective. So, okay. So before we begin, we just want to take a moment and recognize that both of these topics individually are difficult and the source of trauma for many of us. And so I just want to give you all an invitation to self-care. If some of this information brings up feelings or thoughts or just reactions, that you want to attend to that before and after the training. And as a group, I'd like to kind of invite us into a mindfulness exercise to kind of get us in our bodies and in sort of receptive mode. This exercise is something that's adapted from a book called My Grandmother's Hands, which I want to recommend to all of you. It's a wonderful book, and it's really about the way that racialized trauma can live in our bodies and also how we can heal it. So if you can, just take a moment and let's just breathe together. So take a moment and make sure you're sitting comfortably, and begin by taking a few deep breaths. If you'd like, turn your head and slowly look around in all directions, but especially behind you. Orient yourself to the space around you. Notice the height of the ceiling, the height and color of each wall, any doors or windows, any other details that stand out to you. Note what you hear, what sounds you hear, any smells that fill the air, any warmth, coolness, colors that stand out. Sense how your feet rest on the ground, how your body rests in the seat. Now, notice any other sensations in your body. The bend in your knees, your spine. Is it straight? Is it curved? Your belly, is there tension there? Your chest, expanding and shrinking with each breath. Notice what your body experiences inside your clothing. Pay attention to how the body touches the clothing. Starting with the top of your head, bring your attention slowly down through your body. Notice any sensation as it passes your attention. Warmth, coolness, relaxation, tightness, softness, pressure, energy, and numbness. Take another deep breath. And then join us when you're ready. Okay, I'm gonna start by talking very just briefly about why this is an important topic. And I think what we're hearing in general is that we're experiencing as a nation a crisis in mental health, particularly around youth mental health, and that all communities aren't equally impacted. We know that, and so that there's attention to a crisis in Black youth suicide. A lot of this is connected to things that we'll talk about today. But certainly some of it is really connected to the COVID pandemic. And what we all know about that is that that's affecting people in many different ways, that there are higher rates of anxiety and depression that are associated with COVID. People are more socially isolated. We saw that certainly a lot with kids who couldn't go to school. Economic disruption, especially for folks who have jobs that are in industries that are more affected, especially in low-wage jobs. That folks have health concerns that are related to COVID. And that there's certainly so much grief and loss that we haven't even begun to grapple with about what we've experienced during these past 2 years. So I want to particularly focus on, and again, our panelists are going to talk a little bit more about it, but to give you some things to think about as we go in. And so what we know at a population level is there are certain risk and protective factors that are especially relevant for the Black community. So one thing we know is that structural racism plays a huge role in the risk for behavioral health and for suicide. And that is a population that this is a community that is more affected often because of structural racism with unemployment, financial, and food insecurity. We also know that at a population level, health conditions aren't equal. And so we see a lot more comorbidity when it comes to the Black community, as well as limited access to care. But we also want you to keep in mind that there are unique protective factors for this community. And those are things we'll talk about more as well, and things that we want you to honor in the people that you work with. And one is the spirituality, which has been a real refuge and a source of protection and strength for many people in the community. That the strong family and community bonds also provides that refuge and support. And having a positive Black identity, especially for youth, can be a real protective factor because it kind of stands against a lot of what is presented in media and in the culture in general. So these are just some kind of framework ideas that I want you to keep in mind as we listen to our panelist. And I'm going to now turn it over to Sonia, and she's going to be talking about suicide and Black adolescents.
Thank you so much, Shanti. And it's a pleasure to be with you all this morning to talk about a topic that's near and dear to my heart. So I am a suicidologist. I study suicide, and specifically I study suicide among Black populations, centering on Black youth. And so for the presentation today, I'm going to talk about suicide in Black adolescents, but I'm going to do it through an intersectional lens. So I'm going to provide some data, some limited data on suicide as far as gender, and as well as sexual minority status as it relates to race. But before I do that, I want to give you some context on why I've chosen to spend every day of my life on studying suicide, which can seem to be a daunting topic at times, but it's a topic of passion for me. So next slide. So let me just tell you a little bit about my background. So I found some stick figures online. Disregard the sad faces. We were not a sad family, but that was the best stick figure I could find. So I went with what I could find. But in my family, there were four children in total. So I had 3 other siblings, and I was the youngest one. So I'm the baby of the family. And my siblings range in age. And when I was born, the year I was born, my family moved into our first home. And so my older siblings experienced living in a lower income neighborhood and community, but when I was born, my parents had experienced economic mobility, and they moved into an all-white neighborhood here in Charlotte. They were the first Black family in the neighborhood, and they experienced a lot of racism. We experienced a lot of racism and discrimination, but we were also elated to be able to move out of poverty. So next slide. So one thing I want you to know about suicide does not discriminate based on socioeconomic status. So it doesn't matter if you are lower income, middle class status, or higher income status, suicide does not discriminate. And in my family of 4 siblings, 2 of my siblings attempted suicide when I was a child. And both of them I witnessed. So I witnessed suicide attempts in my family with my siblings. We are Black. And let me tell you what happened. I'm not going to tell you specific details because I'll protect privacy, but with one sibling, there was a suicide attempt, and my parents were able to intervene. And then what happened after that? We went to church. We went to church and we prayed about it, because that's what you do as a Black family. You go and pray about it. You turn it over to God, and that's what we did. And there was never really any help given to that sibling. And then there was another sibling who attempted suicide, who required medical treatment. So we went to the hospital. We went to a hospital here in Charlotte. And what did they do? They provided physical health care, because there were some physical needs at the time, but there was no mental health care. So although I grew up in a family where my parents were married, there's a 2-parent household, we had a church up the street. We went to church I want to say every day, because it was every day. Even though we did all of that, there were still some attempts, and we never discussed it anytime after it happened. There was no discussion about it. It happened, and we carried on with life. Next slide. So let me just frame a little bit about what my experiences were and give you some grounding for these suicide definitions. So one thing I want to make sure you know is when it comes to suicide, we don't say, well, the correct language for suicide is now to say they died by suicide. We don't say they completed suicide. That's an insensitive term. So death by suicide is what is more recommended. So suicide is death caused by self-directed injurious behavior. So you engage in a self-injurious behavior, and as a result of that behavior and your intent to die, you die. That is called suicide. And then you have suicidal behaviors, where this may include attempts, ideation, or plans. And you also have an intent to die. So there has to be that intent to die. And if there is the intent to die and you thought about suicide, you planned for suicide, or you've attempted, you have engaged in suicidal behaviors. Next slide. So let me tell you about this continuum of suicidal behaviors. And again, I just want to make sure we're using the same language as we talk today, and that we can learn together on these things. So suicide ideation, we know that that's thoughts of engaging in suicide-related behavior. Suicide plan is when we then take those thoughts and go to the next level, and we start to create a plan. And for many of us as practitioners, that's when I know for me, years ago, we were trained, when it's a plan, it's a little bit more serious. So this is when the person has an idea about the place, the time, what they might use to attempt to die by suicide. And then you have a suicide attempt, which is a non-fatal, self-directed, potentially injurious behavior with an intent to die. So again, there's an intent to die. You attempt to die by suicide, but it doesn't happen. It's not fatal. That is called a suicide attempt. And we put all of those behaviors into what we call suicidal behaviors. Next slide. So in thinking through those suicidal behaviors, one thing I want you to recognize as it relates to Black communities is, for some time, we heard over and over again, Black people do not die by suicide. Black suicide rates are not high. It's something that mainly white people engaged in. That's what the narrative was. And it was in the 1970s, that Black researchers and psychologists began to call that out and say, well, no, that's not really true. We're seeing an increase in suicide-related behaviors among Black people. And we're seeing some shifts and changes that happened in the 70s, it happened in the 80s, and it happened in the 90s, where the Black suicide researchers were identifying these changes. And it was not until the early 2000s that the Congressional Black Political Caucus started to, or actually completed a report called Ring the Alarm, where they started to say, okay, these researchers have been saying for decades that this is an issue. We have to ring the alarm. We have to shut down the United States for a day, or shut down the country, and just make it a focal point of attention, and say something is happening, because these kids are attempting to die, and they're not dying. They don't have the same suicide rates, but they're attempting. Something's wrong. And so this report is what then brought more attention to suicide-related behaviors. So being able to understand what's happening and not concentrating solely on death by suicide, which we do know white individuals do have higher rates of death by suicide, but Black populations have higher rates of suicide-related behaviors. So ideation, planning, and attempts. So when you think about this from a practice-based perspective, it's going to be very important for us to consider suicide risk screening versus assessment. So in practice, we need to be screening for suicide, and we do those things oftentimes with that PHQ-9. You might also do suicide risk screening with the ACTS questionnaire or the Columbia. Those are some of the common suicide screenings, and you're screening for risk. And then once you identify that there is a risk, then we need to go to a more thorough assessment, which would be your suicide risk assessment. And this is when you might engage stakeholders a little bit more, find out what some of those protective factors are, but there needs to be some more intentional assessment. So I did want to differentiate risk from assessment, and you may have already been implementing that PHQ-9 and maybe not recognizing that you were already assessing for suicide risk, but it is a component of that. Next slide. So let's look at the data. Now, this data, for me, every time I look at it, is very alarming. And what I've created for you in this table is across the top, horizontally, I have Black youth rates overall, Black male, Black female, Black LGB. And this is National Youth Risk Behavior Survey data. And I want you to note, for this national survey that is done across the country, they do not ask questions across the country on transgender populations. And so I can only include data on the LGB, which is why it says that on there. And then down the left side, going vertically, you have suicide ideation, planning attempts, and suicide attempts with injuries. These are the reported rates. So these are self-reported rates among high school students, Black high school students, as far as ideation, planning, and attempt. So we can see overall, just from suicide ideation with Black youth in general, you're almost finding 1 in 9 have some thoughts of suicide. They have thought about it. 1 in 9 have thought about it, and even almost 1 in 9 have had a plan. 1 out of every 9. And so I want you to think about the Black kids that you're seeing in your practices or that you're working with, and just imagine 1 out of every 9 having some thoughts of suicide. And then say to yourself, am I screening for that? Am I paying attention to that? Now, when we get to the genders, and again, this is a binary gender in this national survey, unfortunately, but when you look at Black males, we can see those rates for suicide-related behaviors, and we can see that their rates are lower than the Black females. Now, the Black female group gets even more startling when you look at their rates. 1 in 4 almost have suicide ideation. 1 in 4 Black girls, high school girls. 1 in 5 have a plan. That is really serious. Now, what I will bring to your attention with this data is when you look at the death by suicide rates, there is a difference as it relates to males and females, binary again. But when you look at suicide-related behaviors, those rates are highest among Black females. So almost 1 in 5 have a plan, and 1 in 9, almost 1 in 9 have attempted suicide. And then the most startling column is that Black LGB population, where you have 1 in 3 have thoughts of suicide, 40% have a plan, 1 in 3 have attempted, 1 in 3 Black LGB youth have reported an attempt of suicide. This is disheartening. Even when you look at that suicide attempt with injury, 8.8%, so almost 1 in 10, Black LGB youth has an injury, so some type of harm that was done because of that suicide attempt. And so this is what the data is looking like. And I'll bring one more thing to your attention. I don't have it on the slide, but when you look at the differences between genders, typically on average, you find a 2-to-1 ratio. So for every 2 males that die by suicide, there's usually 1 female that dies by suicide. But when we look at the death rates for Black populations, it's a 6-to-1 ratio. For every 6 Black males that die by suicide, there's 1 Black female that dies by suicide. One other reason why this is important, and another reason why I study adolescents, is because suicide is that one health condition, if we put it under a health category, where Black people have, for the most part, maintain better outcomes than other populations. So when it came to death by suicide, we usually had better rates and better outcomes. We have found, though, that that has now shifted. For the first time ever, our kids under 12, our Black kids under 12, have the highest rates of death by suicide of any race. That's under 12. And so our kids in the Black community, our kids are dying by suicide at a longer rate. And so that's killing off our future generations. Whereas if we compare that to the white community, they are dying at an older age when they're older in age. So they've lived generations and had families, but our kids are dying younger. Next slide. I'm sorry, y'all, I get passionate about this stuff. Okay, I have just like 2 minutes left. All right, so this is some data on circumstances preceding suicide among Black females by age. So this was some data when they looked at death data and they examined what were some of the preceding circumstances prior to these children dying by suicide. And the light blue is ages 15 to 17, so that's your high school population. Ages 10 to 14 is dark. It's the dark purple population. And so we can see what was happening prior to their death. For the high school adolescent girls, they had a current mental health problem and they had received some type of treatment for the mental health problem, but they still died by suicide. They were in our offices. They were receiving or had received some type of treatment, but they had still died by suicide. That's disheartening. And then if we look at the dark purple, what we're seeing as one of the main preceding circumstances is that family relationship problem. So imagine a Black kid coming in for treatment, let's say for individual therapy, and they're dealing with family issues. Do we know how to work with the Black family? Like if this is one of the preceding circumstances, what are we really doing collectively to engage that family to create more protective factors? Okay, let me go to Black boys, next slide. Black boys, you see some major differences here. The light blue here is ages 10 to 14, so that's more of like your middle school population. The dark purple is your high school. With the young Black boys, the family relationship problem is for 10 to 14, that's the largest preceding factor. So family, again, it goes back to our whole ideals and the notions within the Black community of collectivism. And also that crisis in the preceding or upcoming 2 weeks. So there was some type of crisis related event happening. And it was after that crisis that these kids decided to die by suicide. Next slide. All right, so what is our call to action for clinicians? We have assessment, intervention, and advocacy. For assessment, one thing I want to bring to your attention is that for depressive symptoms, Black youth are more likely to have somatic complaints or relationship difficulties. So those depressive symptoms may show up as relationship problems. And so it's going to be important to tease that out a little bit. Also inquire about the youth's beliefs about mental health and suicide, as well as the family and community beliefs. Is it something that they don't talk about? Is it something that is discussed? Is it something that they're just told to pray about? Like, what are some of those beliefs? And where might be some of those protective factors? That's my timer, but I'm gonna just finish this out. And then intervention, focus on racial identity and lived experiences. We have to acknowledge that these young Black kids are coming into our offices dealing with a lot of what's going on in the world. Shanti spoke to it earlier, the racism, the discrimination, sexism, heteronormativity, all of those things, they're bringing all of that into our offices, and we have to acknowledge those identities. Also consider the community context. And as far as advocacy, we know based on data that people of color, like so in the Black community, our healthcare outcomes have been found to be better when we're treated by someone who looks like us, because there might be more of an understanding of what we're going through and better communication, et cetera. And so support your Black healthcare professionals, and also utilize alternative avenues outside of the healthcare system for care. And then my last slide features for you you can go to the next slide, a link. It's a resource that was released. I'm not sure if you all have seen it, but it's a blueprint for youth suicide prevention. It's a great guide for outpatient providers, pediatric healthcare providers, on how to implement suicide prevention in medical and community settings. It's a free guide. It has great information. If you have a chance, check it out. And that concludes my talk for this time. I look forward to some questions a little bit later on, and you guys are in for a treat with Dr. Vance and Victor Armstrong. So I'm looking forward to hearing their presentations as well.
Great. Thank you, Sonia, for packing so much great information. And we will go ahead and make the PowerPoints available and send those out to everyone as well. So I'm going to turn it over to Dr. Vance.
Okay, I was trying to unmute. Thank you. It's so good to be here. Thank you, Sonia. We've been working together for some time now, everybody. So I was like, wow, she set me up perfectly. I'm so excited to be here with you all today. I am actually with North Carolina A&T State University in Greensboro, North Carolina, and I would just want to thank Shanti as well for inviting me to this platform. And I'm super excited to be here with you all today. I am a social worker, a researcher. Also, you will find me at the intersection of mental health and social justice. So really looking at mental health disparities is very, very important to me. And we're going to talk today and continue this discussion around intersectionality. So I'm going to spend some time with you talking about Black women's mental health, specifically looking at gendered racism and the impact of that on suicide outcomes. Next slide, please. So I've already introduced myself and where I am. And so today we're just going to look at the intersection of Black womanhood and how that's critical to really holistically, from a health perspective and a mental health perspective, and understanding the mental health of Black women. We're also going to look at some specific risk factors. And then I will end by talking about some research and practice implications by using an intersectional suicide risk model, and hopefully talk about how we all can do our own work and really being aware of the things around racism and sexism that will help us in the communities that we're working in. Next slide. So as Dr. Richardson had talked about, I mean, we've really been seeing some increasing trends in the suicide rates in the Black community. And prior to the pandemic, we were seeing those rates increase dramatically, and we're expecting that to continue. And among female youth, specifically between the ages of 15 to 24, we've seen an increase in suicide deaths by about 59%. And historically, we haven't thought about Black women in suicide when we're talking about that. Sonia also mentioned some of those health outcomes, right? So there's actually three paradoxes when we talk about suicide outcomes, despite what the rates are. So we have the Black-white paradox. So this is about race. This says that white people die by suicide, and it suggests that despite experiencing racism at all levels, that mental health outcomes are comparable or better for Black people than white people. We have the gender paradox, which basically says, right, that men die by suicide. So this is guided more by socialized gender roles. So white people die by suicide, right? Men die by suicide, and how they engage in behaviors, because as women, we are really taught to deal with our feelings, and we're not expected to engage in any masculine behaviors or even any risk factors that would put us at a heightened risk for suicide outcomes. Then we have this third paradox that really looks at African American women. And basically it says that Black women should be used as a model in facing adversity. So this is the focus more on protective factors, such as religiosity and social ties, which supposedly protects Black women from suicide, although they live in a world where they navigate daily gender and racialized oppression. And so again, we're seeing that Black women continue to have poor physical and mental health outcomes, higher rates of illness across and over any other non-minority groups. And this is something that's important for us to look at. Next slide. So we want to really look at what is causing these increases. What's important for us is because established risk factors really have not been associated with suicide risk in Black women. So as social scientists, we're really tasked with asking several questions, which I think is important for all of you all in the audience as well. Why are Black women experiencing this increase in suicide risk? And how do the psychosocial aspects of race and gender really put them at risk? This is where intersectionality comes into play. And this is important for all of us because we we all hold identities of privilege and oppression based on our social identities. And in order for us to work within communities, we have to be very aware of our own identity and our own privilege. And so we talk about intersectionality in this intersectionality framework, or this analysis that's important to center Black women's lived experiences, because we want to consider the ways in which racism and gender-based oppression really shape the mental health outcomes and suicide risk. So I want to talk about some specific risk factors that I want to highlight specifically that we're looking at currently. This notion of gendered racism that really hasn't been studied in terms of how risk factors and things come up and show up for Black women. If most of the work that we've done have been on white communities and white populations, we know that depression, anxiety, post-traumatic stress disorder have been linked to suicide outcomes. But we need to look at how it shows up in people differently based on their identities. So gendered racism is exactly what it sounds like. This occurs when an individual faces racism and sexism at the same time. And these intersecting oppressive acts have already been tied to negative mental health outcomes and greater psychological stress in studies of Black women. We specifically want to know more about this in suicide risk. Then we have the strong Black woman schema, or the superwoman schema. So Black women have really adapted to this strong Black woman script as a means to navigate this race and gendered hierarchy in society. And the tenets of the schema include this obligation to manifest strength, suppress emotions, resist vulnerability, or being dependent on anyone, and also this obligation to put others before themselves. This we are seeing having very negative outcomes, and we really want to look at this in regards to suicide risk. And then these other psychosocial risk factors that I mentioned in terms of mental health and these mental health issues. And we specifically want to look at racialized gendered stress. And what does that look like specifically for Black women? Because Black women experience that because of those intersecting identities. And so again, the focus needs to shift to how these issues are manifesting and show up in the lives of Black women. Next slide. So my colleague, Dr. Jeanette Wade, who's also at North Carolina A&T, she's a medical sociologist, she's trained in gender studies. We've developed this intersectional suicide risk model. This is really important when we're talking about integrative care. We know that mental health impacts physical health impacts mental health, and we're seeing these rising trends and these poor outcomes. So what this model does is it accounts for these systemic factors of racism, sexism, and the fact that Black women are not even seen as human. And we need to look at ways that we can rehumanize and where these specific risk factors, so all that I've mentioned earlier. We want to really look at all of these risk factors that women, that Black women particularly navigate every day. What is this creating? So we want to look at these racialized, genderized stress and how that is increasing and impacting mental health, related already to the predictors that we know, like I said, depression, anxiety, and post-traumatic stress disorder. Next slide. So what's important here, and this is where I really want to probably spend most of my time, is that we as a community of practitioners, again, educators, researchers, however you identify in your professional realm, but I also want to encourage you all to think about this personally as well. There really can't be any discussion of Black women's health equity at all unless it considers the institutional and individual levels and forms of racism and discrimination against Black people in general. Nor is a review of health equity among Black women complete without this understanding of this intersectionality of gender, race, and those historical contexts that have accumulated to influence Black women's health. Now, intersectionality is not new. And as Sonia was talking about, neither is researchers looking at Black people's mental health outcomes. But we know that systemic racism and white supremacy culture has probably not allowed us to really put those things in the forefront. And so it's really important that we're always looking at the multiple identities that people hold in order to really understand. And so again, by doing this, we have to consider gendered racism. We have to consider and assess how Black women experience this and how they respond to the specific and unique stressors because of their identity that's associated with this stress. And it's really important for us to think about our own bias, right? We have to think about the influence of white-centered practice in assessment and interventions. So if I look at my own identity as a white, cisgender, heterosexual female who got my graduate degree in the early 2000s, I really want to think about what that looks like for me and how I show up. What does that look like for me when I'm joining practitioners and researchers of color? And also, what does that look like and how I've been taught and how I've been socialized to work with people of multiple marginalized identities? So again, this is really important for us. And so when we think about screenings and assessments, we have to think about and check our own bias first and foremost, before we even think about how do we use some of these standardized or these formalized assessments for suicide risk. So a lot of people may know, or you may have heard about the Columbia Suicide Severity Rating Scale, the same way that all of us go into the medical office and you actually fill out what Sonia was talking about, the patient health questionnaire. But the Columbia doesn't account for race, gender identity, or other cultural variations. So we need to become educated on more culturally responsive assessments. So I would encourage you to take a look at the cultural assessment of risk for suicide as a screening measure, as a best practice, especially for working with non-white groups, and also thinking about how do we show up and do intersectionality informed and culturally responsive interventions. First of all, we need to remember that most interventions that are here, they've not been developed with Black women in mind. Most interventions that we have for Black youth have not been designed with Black youth in mind. So we have to look at how do we come up and how do we do this and how do we tailor interventions that are important. We've got to go into the communities. We have to understand and have these better understanding of lived experiences, and then be able to provide what the communities are needing. And I'm hoping that what you all are going to continue to hear by our next speaker, Victor Armstrong, the same thing with what Dr. Richardson was talking about, again, is having this equity mind frame, and also just really stepping back and thinking about what are the best things that we can do in order to make sure that we're serving in an equitable way. Thank you all for your time. And I also look forward to questions at the end of the presentation.
Thank you so much, Michelle. I'm going to now turn it over to you, Victor, if you want to.
Thank you so much, and I appreciate very much the opportunity to be here with you all today. So just to kind of frame what I'm going to be talking about, I am going to be talking about mental health and the Black community from a health equity perspective. The role I currently sit in is Deputy Secretary for Health Equity, Chief Health Equity Officer for the state of North Carolina. So a lot of what I'm going to share is really more from a systems perspective and how I think that we need to be approaching suicide awareness and mental health in general in the Black community. And I always like to frame conversations when I'm talking about suicide by saying that when I talk about suicide, I want to be clear that we're not talking about suicide as a disease. Suicide is not a disease. It is the worst possible outcome of the culmination of a lot of very complex things that often includes mental health. But because it is a culmination of a lot of very complex things, that also means that we have opportunities to intervene. And unfortunately, we haven't done a great job of intervening as it pertains to suicide for anyone, but certainly not as it pertains to Black people. So let's go to the first slide. So the bottom line, these are just some overarching things that I think we need to keep in mind as we're having this conversation. Exposure to multiple traumatic events and/or chronic toxic stress can lead to lifelong physical, mental health, and substance use problems. And COVID-19 has exacerbated exposure to unimagined stresses on families, children, parents, caregivers, in addition to communities. And I think that is especially true of Black communities, because when we look at the past 2 years for Black communities, it hasn't just been the time we've been exposed to a physical virus. It is also time we've been exposed to a constant barrage of really racism. We've spent an expanded amount of time seeing the George Floyd trial, what happened to Ahmaud Arbery, what happened to Breonna Taylor. All these things work on the mental health and mental well-being of the Black community. Also, exposure to trauma increases a person's likelihood of being re-traumatized by engaging in high-risk behavior, including inappropriate use of drugs and alcohol, things that can put people at a higher risk for suicidal behavior. And people serving systems need to be trauma-informed and resiliency-focused. A trauma-informed system understands the prevalence and impact of trauma exposure and has the skills to address it. And this includes complex trauma. This includes historical trauma that's been faced by Black people in America. The resilience-focused system helps those in recovery from trauma understand that they can overcome their past, believe that they can move forward, and be optimistic about what they can achieve for themselves and their families. And we cannot achieve, something popping up on my screen. We cannot achieve equity unless we acknowledge that social drivers and systemic stressors, including racism, classism, sexism, geography, access to services, socioeconomic challenges, and social opportunities have contributed to and continue to contribute to many stressors experienced by historically marginalized communities. Next slide. So the reality is that mental health and addiction services are about more than addressing the presenting issues, but also are about the intersectionality, as both Sonia and Michelle talked about, the intersectionality of presenting issues along with race and ethnicity and sexual identity and socioeconomic challenges and health disparities, all of which impact mental and emotional well-being. Next slide. As a system, our goal should be to create a sense of belonging for the people that we serve. And I think that's one of the things that we need to really take into account, is that one size fits all does not work. We have to create a system where there's a sense of belonging for all who are attempting to access services. We have to intentionally promote an inclusive, equitable system that reflects the communities that we serve, where everyone feels a sense of belonging, where our diverse backgrounds and experiences are valued and recognized as strengths, and our services are guided by a desire to serve and not by our perceptions of who people are and our perceptions of how our resources fit them. Next slide. So what is our path forward? Next slide. First of all, we must earn trust from historically marginalized communities and incorporate the voices of lived experience into mitigation strategies. That means that we have to do the work of undoing a lot of the mistrust that has already been established by us not serving communities properly, and then incorporate those voices of lived experience. And when we talk about lived experience, it is not just lived experience from the perspective of people with lived mental health experience. It is that, but it's also acknowledging there's a difference in being a 35-year-old white male who's experiencing a mental health emergency and being a 35-year-old Black male who's experiencing a mental health emergency. The response is going to be different. The access to resources is going to be different. And so we have to incorporate those voices and build a system that reflects the needs of the people that we're trying to serve. Create and follow a strategy of partnering with historically marginalized communities, but by not only sharing accurate information about treatment and access, but by listening to people's concerns, accepting the fact that we have missed the mark of equity for too long, and answering their questions with transparency. And sometimes that means being willing to sit and let people wag their finger in your face and tell you how you failed them, because that's a part of the trust building process. And by being intentional about not only training providers in cultural competence and cultural humility, but also reviewing our treatment models and seeking to make sure that our treatment takes into account the realities of social drivers, including historical trauma and structural racism. And I would add to that, that is more than just teaching providers to be culturally competent and teaching cultural humility. It is about how we reach into the Black community and build a workforce of people who look like the people that we are attempting to serve. Next slide. We must also form partnerships with community-based organizations and coalitions to increase access to care, reduce stigma, and improve outcomes among historically marginalized populations. And for me, a large part of that is looking at where are those trusted voices in the community and where are those established relationships, including the faith-based community. How do we build those resources into our response as we try to mitigate a lot of the challenges that lead people to suicidality? Work with community partners, community media, and grassroots messaging to educate communities to combat stigma and to address concerns about receiving treatment. Embrace the mindset that community collaboration affords us the opportunity to provide not only an evidence-informed response to the needs of those we serve, but also a community-informed response that takes into account the nuances of disability, race, ethnicity, culture, language, geography, and socioeconomic status. And these are all social drivers that impact an individual's ability to navigate their healthcare journey. Next slide. And we need to leverage expertise of providers of color. And I think Dr. Richardson spoke to this. Providers of color who have traditionally served historically marginalized communities, often without access to government grants and contracts. And we have to focus on justice-involved populations, including rethinking how individuals seeking addiction treatment enter services. Court-ordered, legally enforced treatment should not be our only strategy. When we have people who are seeking services and we have this somewhat unholy alliance with law enforcement where most of the people engaging in addictions treatment are court-ordered for treatment, and the alternative to accessing that treatment is you get arrested and sent back to prison, that's not a good strategy for how we provide services to Black and Brown communities. Next slide. We have to ensure that our approach is data-driven. Prioritizing equity data requires that we focus on quantifying the disparity while recognizing and acknowledging longstanding inequities. And both Sonia and Michelle talked about this. We have to look at where the disparities are currently occurring and then utilize that data to help us build our strategy going forward. We have to develop and follow a data strategy that will identify the underlying social inequities and the resources needed to afford all patients, consumers, guests, constituents, whatever we want to call them, a fair and just opportunity to achieve their healthiest outcome. Next slide. And our evaluation efforts cannot be limited to measuring average impact on the health of a whole population. Instead, we need to measure change in outcomes among selected disadvantaged groups, quantify the size of gaps between disadvantaged and advantaged groups, and seek to engage in disproportionately impacted communities, in solution generation, and then measure to determine if efforts have been successful. When we talk about how we both mine data and report data, one of the mistakes that we have made, and I'll speak again from a system perspective, is that we talk in aggregate numbers. And when we introduce resources, we introduce those resources in ways that we're measuring aggregate outcomes. But we could introduce a resource that helps 90% of the white population and still miss 90% of the Black population. And so we have to think about how do we provide resources that speak specifically to the needs of the Black community. Next slide. Historically, not all communities have equally benefited from the advancements in science and thought leadership. And if we don't build equity into our programs and practices on the front end, if we don't recognize the fierce urgency of now, the most powerless and vulnerable among us will not receive equity or justice, which means that we will continue to see the trends in suicide among Black community, as both my colleagues have already spoken about. And I believe that is my last slide. Thank you so much.
Okay, thank you. I'm gonna pull everybody up. Thank you so much. All three of you have, I've been learning from you, and I feel so inspired about what you have shared today. I think it's wonderful to have a panel of social workers. And I think, as Michelle put so well, like, it allows us to really focus at that intersection between behavioral health and social justice. One thing that really stood out to me that is just how so much of the helping system, so much of the social work profession is really founded on principles of white supremacies and values of white supremacy. And so what that requires us to do is really undo that training, undo those assumptions, and dismantle and begin to reimagine these systems and the ways and practices and how we engage. And that means sometimes getting out of our comfort zone and admitting when we do things wrong and changing and being open. And so I'm really excited to have this conversation here. So I guess I have a couple questions. I think we can also open the chat. People, I guess, I'm not sure if we have a large group, but it's also possible we could let people like unmute and ask questions directly. But I guess I want to start by inviting the three of you. Are there any things that you want to ask each other, or are there things you want to comment on that you heard your co-presenters talk about that you just want to dig into a little bit more?
I do have one statement, and that is, and you know, Dr. Richardson talked about how suicide doesn't discriminate, and you know, and that's so true. And I think the thing that I would add to that is neither should our interventions. And I think part of the tragedy thus far and the travesty thus far is that our interventions have discriminated. They have not been created, taking into account the Black experience, and I think that's part of what has to change.
Do you guys do you have some thoughts about that? About do our interventions discriminate in some ways, or how do they discriminate in ways that are that we can kind of illuminate for our audience?
Yes, I definitely appreciate that comment by Victor, and I would totally agree with that. And I think, yes, I do believe our interventions do discriminate because we are operating from that, oftentimes that white supremacist lens that we've been trained in, and that saviorism lens of needing to save populations and people. And so I think it is exactly what you said, Shanti, about dismantling and disrupting. There is a lot of that. And I will tell you, as a practitioner, so I am a practitioner, and in my practice, in my agency, when we talk about these screening tools, one thing we've recognized, and this is something that I plan to gather research on once I have some time to do this thing. But one thing we recognize in practice is when it comes to our Black populations, because our practice is about 90% Black clients. But when they come in for treatment and they're taking these screening tools like the PHQ-9, the GAD-7, et cetera, we find that their rates or their scoring on these tools are oftentimes very lower at their entry into services. And then when we administer this test again in 3 months, what we started finding was that the scores were increasing. And so it would make you think, okay, what's happening? Are they not getting better? But what we have found is it's not that they're not getting better, it's that they've developed a level of trust where they can be honest on these screening tools with us, because they feel like we can then hold space for how they're really feeling. Now, from a systems perspective, I'm looking at Victor for this one. He can't tell I'm looking at him because we're on virtual. But from a systems perspective, when it comes to our outcomes and reporting to insurance companies, we are penalized because it looks like our clients are regressing, when in fact, our Black clients are building trust and then feeling like they can be authentic on these screening tools. But this is something that needs to be researched, documented, so that we can have an argument in case to then say, okay, we do not need to be penalized as Black providers because our outcomes look different. We need to change the system to honor our differences and also understand that some of these screening tools, like Dr. Vance said, don't really screen for culture and race. And so there's already some inequities with that. And I'm going to stop there because I can keep going on and on, but that's just my 2 cents.
I love what you're saying there. And it makes me think, Sonia, too, like, one thing I think we have to truly question is like why people have to screen to get what they want. Why is it not enough to say what you need? You know, because we're kind of making the price of getting resources or getting information or education is that you have to be suffering enough, or you have to share your worst trauma with a stranger. And that is the medical model, right? Like that's medical model. We like screen, we diagnose, but I think we have to really critically examine like what are the assumptions in that model and what does that say about how we value people and what the price of care is. Does everybody deserve care, or do just, yeah, anyway, that's my.
You know, one of the things I would add too is that one of the things that we are trying to do differently at the department as it pertains to equity is really to think differently about what we consider to be data. Because data has always been data that supports either what the payer wants or you know, what we want as a system, what we're trying to measure. What we have not done is really take into account what the utilizers of the programs and what the people who are receiving the programs, what they want us to know and how they want things reported to them. And so we're trying to look differently at how we decide what we consider to be data, what factors into the way that we evaluate and reevaluate things. And what Dr. Richardson is talking about is exactly that. We need to also be looking at the people who are utilizing these resources and asking them, what is your feedback to how well our tools are even measuring what it is that you want to measure, and asking the same questions of payers. And I think part of the problem also is we need to decide what question are we trying to answer? Because I think that's part of what's missing. I don't know that we understand what question it is that we're trying to answer. So the way that we're asking the question doesn't really get at whether we're making progress. It just gets at, have we hit this mark, this predetermined mark that we've set?
So I don't know if we have some questions from the audience, or Michelle, I want you to give you a chance to kind of weigh in as well. So from a Black women's perspective and based on your research, what are some things that you think we really need? You already mentioned a little bit in your presentations, but what are some things that you'd like to see changed?
I think what's important, and I kind of just really want to highlight some of the work that Sonia and I are doing together, because we really come in with this very unique perspective, and we're able to really break down some barriers when we're looking at what you all had mentioned earlier about everything, how we've been trained, how we've been socialized, the data, what questions we're asking. And so I want to just really lift up sort of this cross-racial, cross-cultural work that I believe that we really need to do as a profession, between practitioners of color and white practitioners, and also thinking about how interventions, specifically to kind of get back to that question, we don't have to just do interventions in inpatient psychiatric facilities. That's not generally where our racialized and minoritized youth are going to be found. And we need to figure out how we can do these interventions in the settings that women and families and children are in every day. And that's school settings, that's church settings, that's community settings. And I had said this on a presentation one other time that, I really believe that healing the Black community starts with really healing and humanizing Black women. And that's why I really believe that this perspective is so important. And I'm privileged enough to be in this space, in that, when we talk about all of the injustices and things that are happening in the Black community, I mean, the Black women are the mothers of the Trayvon Martins, and the mothers of the George Floyds, and the partners of the George Floyds, and the daughters of, and the Breonna Taylors, right? And so I really think that we've got to just do a lot of better work together in understanding these very important lived experiences. And we've got to allow people in the community to guide our interventions.
Yeah, I really resonate with what you're saying, Michelle. And sometimes what I hear from Black women in the communities is they are doing this work, for their communities, for their families, for the people they care about, but it's unpaid work, right? And it's work on top of everything else. And I'm just wondering, Victor, you had a slide where you talked about engagement with communities and community organizations and natural helpers. I'm wondering what you all think about what is the role for the community and maybe people who aren't professionals, but who are natural helpers, and how are they part of the solution?
Yeah, so first I would say, kind of going back to my earlier point about thinking differently about how we collect and utilize data. I think to Michelle's point about paying attention to what's going on with Black women, I think the other thing we need to be looking at is the resiliency of Black women. Because in spite of all of the burden that Black women carry, the suicide rate for Black women is much less than other demographics. So what is it about the resiliency of Black women that we need to be learning from and studying, knowing the burden that they carry? And so I think that is the kind of thing that we need to also build into our system, understanding where those strengths lie and utilizing those strengths to really support people who are experiencing crisis. Now, in terms of how we embed that voice of lived experience into our systems, I think one of the opportunities we have in front of us clearly is 988, and making sure that as we're building out 988, that we're building a system that's designed for and by the people who are going to be utilizing it, and not just built from the perspective of legislators and payers to do more of the same, which has not been very effective at all. And when we're doing that, making sure that we are looking at intersectionality. Again, there's a difference in being a Black male or a white male who's having a mental health emergency. There's also a difference in being a 35-year-old white male and a 70-year-old white male who's experiencing a mental health emergency. And so I think we have to build those different perspectives. And I think there are ways of doing that. We see some of it with Medicaid transformation and how we're looking at healthy opportunities, with opportunities to build community health workers into the work. I think there's also a strong opportunity for us to look at how do we make sure that we are also embedding that peer expertise into the community health worker workforce and paying those folks a living wage to make sure that what they're doing is sustainable. And at the same time, working on workforce development in a way that creates a pathway forward, that someone who comes in as a peer support specialist or a community health worker, but wants to ultimately be a social worker or a psychologist or a psychiatrist, that we create a pathway forward for them to do that. I think that both helps us to build our system. I think it helps to build trust in the system. And I think it also gives us the way of creating a more diverse system that looks more like the people that we serve.
Thank you so much for that. I know that we have a couple hands raised, and also Sheena DM'd. Sheena, do you want to go ahead and unmute yourself and ask your question, and then we can go to Elizabeth and Maruka next.
Yeah, thank you. So I was just asking how we can participate and provide information for this research and remain practitioners, because my heart is to continue to practice, and I would love to go get my PhD, but I want to do the work. I want to be boots on the ground. So how could we contribute to that research?
I would, one suggestion would be to join alongside suicidologists. So as I stated, Michelle and I, and Victor probably, are all suicidologists. We study suicide. And so unfortunately in the United States, when we look at social workers who are studying Black suicide, I was saying earlier, there's probably under 10 of us that are really focused on this field. And we have 2 in North Carolina, 2 who are full-time studying Black suicide. So connecting with the Black suicidologists, or just suicidologists in general that are studying Black issues, because we have, Michelle and I have a monthly lab space where we bring community partners to the table. We're talking through interventions. We're actually writing a manuscript now with our community partners on North Carolina suicide trends among youth. And so there are efforts and opportunities to get involved, and just reach out to your researchers who are involved in this work, and we can pull you into the lab, because we need that practice-based perspective as well. So send the email, reach out if you're interested. And then just identify those organizations that are involved in the work, and maybe, see what opportunities they have to partner.
Thank you. Elizabeth, do you want to ask your question?
Hi, good morning from Washington State. I know it's the afternoon there, but y'all have just lit a fire in me today, and I love the systems discussion. I am both that macro and micro social worker, and it's not necessarily a question. And we talk about, how can we do all this? And I really feel like our schools of social work, UNC Charlotte, we have a really good opportunity to educate the public about what we can do and how we can be a part of this. So I think Sonia and Michelle, I love it that you're bringing the community to the table, because Victor's right. What question are we asking? How are we asking it? And we're missing the point, both as payers and as legislators. And I think we move too fast. So I think in schools of social work, I think we have a really great opportunity with our students and, even associate licensees that are in the community. And how do we talk about the work that we do, and how do we partner with our folks in the community? So I think schools of social work are in a really unique position to leverage individuals that come in for that education. And Victor's right. How do we make a pathway? How do we make this affordable? This is this is a really common question that I continue to wrestle with in my administrative work as a social worker. How do I hire and bring on board therapists, practitioners, front desk workers, folks that look like people in the community? And it's really difficult. And I really come back to the systems perspective. So each of you have said everything that sits in my headspace, and I really appreciate it. And I appreciate the work that UNC Charlotte's doing, Dr. Vance at A&T is doing, because it needs to be brought out. So I wanted to say that, the schools of social work are in a really unique position to partner with communities. So thank you for today.
Wonderful. Thanks, Elizabeth. Maruka, do you want to ask your question? Unmute.
Thank you. I too have more of a comment rather than a question. First of all, shout out to everyone on the panel, but Dr. Vance, who is my colleague at North Carolina A&T, I'm so glad to be here. And she and I have several conversations about this a week. And, I am a practitioner, an educator, and I think one of the things when I think about suicide prevention in the Black community and the LGBTQI community, which are communities that I strongly serve, is we need relationship-based crisis management. The first time someone sees a practitioner shouldn't be when they're in crisis. And I think that we really struggle with that. When we talk about the payer model, it really prioritizes a single incident of crisis, but we know that crisis isn't a single incident. So much has happened before that person gets there. And if we can really think about ways that the first time a person sees a practitioner isn't when they're in crisis, or if they already have that relationship. So I noticed when Sonia was speaking, she was saying that for Black girls or women in particular, that they've already are in treatment when there's a suicide attempt. And so how do we leverage the treatment that they're in so that becomes part of the crisis prevention and crisis management aspect? In my own practice, I'm trying to figure out ways how to do that so that it doesn't become just call this random person that might be a police entity, or you might be involved with the police and this kind of thing, so that we can prevent your suicide. But how do we leverage the practitioners that are already seeing the people to respond to suicide and crisis? So if anybody wants to partner with me on that, I can do that. I would love to do that.
That sounds like there are a lot of people who want to work together on this, which is super exciting and generating. I see there's a question from Delton Harris. Delton, if you're here, if you want to unmute and ask that question of the panel.
Sure. Hi, everyone. So my question is to Mr. Armstrong regarding data collection. So I am a PhD student, and what I'm finding is that the data available doesn't, as you said, or as the panel has said, have a cultural component to collect this data. And also what I'm finding is that the questions that I am interested in that are more so about culture and experience that relates to my specific outcome of HIV testing is not interested by my colleagues or by grant holders, because they aren't, experiences are subjective, and at least what they say are subjective, and don't exactly, or don't have this rigorous methodology to analyzing it. And so going for, like, do you see a plan going forward in how to collect this data that directly correlates with uptake in health services, healthcare services, and how we can actually capture the information to then provide equitable resources and equitable resources and services to the Black community, if that was
Yeah.
clear.
So first, do I think there's a path forward? Yes. And I say that for a couple of reasons. One is because the system we currently have didn't happen by happenstance. We built the system. And if we build an inequitable system, we can build an equitable system, but it will take a lot of intentionality. And I think the way that we get there is in part by looking at building out on some of what we put in place to respond to the pandemic. What we had to do in responding to the pandemic was we had to partner differently with the impacted communities. And we had to bring people to the table to say, not only are we seeing disproportionate, disparate outcomes because of existing health disparities, but we don't have the resources in place even to address it. And we don't know the questions to ask to be able to address it. We don't know how to build the trust in the community that we need to address it. We've done a lot of work to turn those numbers around, but the way that we did it in large part was by trusting the voices of the people that were being impacted and asking them, what's important to you? What do you need to know? What do you need to hear? How do you need to hear it? Who are the folks that we need to bring to the table to communicate this to? And then who do we need to be, having to take that information back to the community? So I think part of it is asking the right questions. And, again, the thing with COVID was the questions were pretty obvious because the numbers were in our face. And so I think part of what it's going to take for this, to change this path forward, it is going to take a lot of intentionality. So I think it's a heavy lift. I won't deceive you. I think it is a heavy lift, but I definitely think it is doable if it is something that we choose to put the resources behind and bring the expertise to the table.
I would like to just respond to Delton as well quickly. Two things I will say is that as a result of a lot of the social unrest and the pandemic that we've seen over the last couple of years, there has been more funding and more attention to research around Black communities. And as a researcher, we're grateful for that. Unfortunately, those outcomes are not what we want to see. So do not get discouraged. I think that you are going to have access to more data. And I also just want to take a point to say that as a PhD student, don't lose focus on what's important to you. And you know that the lived experiences and the voices of these communities are important. And I too was fought very hardly about the population that I was looking at specifically. And it is important, if you need to look at qualitative data, then you do a qualitative study. It is important for us to have that information, and we can always support that with quantitative data later or vice versa. And so I just want you to hold strong, because we've all, a lot of us have been there, and reach out to other scholars that have done research that you're interested in, and particularly Black scholars. And I believe that they'll support you and connect you and give you what you need to make sure that you're getting what you want to make an impact with your research in your doc program. So I wish you the best of luck.
Thank you.
Well, I think we're right at time. I don't know if there's a last thing that you want to leave us with, like in 15 seconds. Any last words of wisdoms or takeaways? This has been a very inspiring presentation. I think I can see like our audience is super engaged. I think maybe we need to think about a part 2 to kind of go deeper, because it feels like we just scratched the surface. But I'll let just to let the audience know, like I will go, we'll be going ahead and sending a recording and also the PowerPoint so that you have those for your reference. But I want our presenters to have the last word if there's anything you want to say before we close.
I'll just add, thank you so much again for creating this space for us to have conversation on this very important topic. If anyone is interested in partnerships, please reach out to us. We are more than happy to have conversations. And thank you for prioritizing the needs of this community.
And I just want to say thank you as well. Thank you to everyone who tuned in. And I am a fan of the work of both Dr. Richardson and Dr. Vance. So it has been a treat for me to be on the panel with them. So thank you all so much.
Yes, and I just am grateful to be here with you all as well. And I just, as Sonia had a call to action, Victor had a call to action. And so let's not walk away today without doing something different or bringing things to the table in our practice, in our community, having these conversations, calling in people that we need to make some changes to really deconstruct and work within these systems that, as Victor so eloquently said, have been built on purpose for a purpose. So we want to break those down on purpose for a purpose. So have a great and wonderful afternoon, everyone.
Thank you all so much.